So this session is a live in a box case with a long diffuse disease PCIs as our main topic. Um, so co-chair with me is Dr. Rosalie from CVS KL, Singapore, Malaysia, and we have a panelist of Professor Yeo KK from Singapore, Dr. Hoàng Văn from Hanoi, Dr. Anfazir Omar from Malaysia, and Dr. Frankie Tam from Hong Kong. So let's start the session with the lecture from Dr. Rosalie. Long diffuse coronary artery disease, is there any optimal approach?
Thank you very much, Hui. Um, Congratulations for the second SIF. So I don't really have any conflict of interest to this lecture, but when this is a definition what is diffuse coronary artery disease, they tend to be long, more than 20 mm, and really inside the plaque, there's actually different plaque composition within the lesion itself. What are the things that comes to my mind when I have a patient with diffuse coronary artery disease? Firstly, the patient characteristics, they tend to be diabetics, especially in our parts of the world, females, familial hypercholesterolemia. Then the lesion itself, they are more complex. They tend to, of course, long lesions, different morphologies. Then the vessels are tapered. You have got bifurcation of the side branch excess. No, and not uncommonly, they present with CTO. And it's the thing about diffuse disease is that it's very difficult to identify normal to normal lesions. That's a lesion that you want to treat, especially if you have to stents. You don't want to stent too long, isn't it? Then obviously the treatment challenges, the procedure is going to take longer, more devices, more costly, and quite often you may even have to stents, and the stents are long, and the stents are sometimes you have to overlap stents. And obviously they come with a poor outcome. So diffuse disease is not is still a challenge in terms of treating. Now, the stent itself, and this is an era of still era of stents. Hopefully, it will change in the future. The longer the stents, the higher the risk of complications or outcome. And this is just not with stent thrombosis. It is also with regards to MACE and all the drug-eluting stents are in the market. The longer it gives the same results, which is the longer the stents, they are not very good. Also, the fact that you also have stents which are overlapping. Overlapping stents are not a good idea if you can avoid it, because here you have, if you have a single DS, they do the best, but if you have multiple stents, if they overlap, then the outcome is poorer than if you have multiple stents and there is no overlapping. So, just a case in point that years ago when Cypher came out, a month or two, 1.5 months after it came out, we were very excited. We were actually doing much, much more. And this is a patient had 2 long Cypher stents, did fairly well over 6 years. But then she came back, and this is a long in-stent restenosis that in the end we treated with a drug-eluting balloon, and she lasted for more than 7 years. But still, the problem about long stents in diffuse disease. So what is required for optimal treatment strategy? If you look at what is ideal, and sometimes I think we should try to do what is ideal as much as possible and work towards it. Obviously, imaging is key, and this is data for long stents, and this was published about a decade ago, that IVUS guided is much better than angiographic guided PCI. And it's not just that. If you use IVUS, you have to try to ensure you get good results. If you use IVUS in this case and your stent is not optimized, then the outcome is poorer than when you get stent optimization. So image it and then act upon it and to get as good results as much as possible. Now, this is IRIS-DS registry showing that actually if you have shorter stents and if you do the treatment well, there is no difference whether you use IVUS or otherwise. But once the stents are longer, more than 23 mm, then the difference is very clear. What is interesting in this IRIS-DS registry is that if you do IVUS guided PCI, whatever the stent length, at least in this registry, there is no difference. What made the difference is that if you don't use IVUS, then the longer the stent length, the higher that risk. What do we do, or how do we use the imaging, both either OCT or IVUS, the MLD max, which is very clear in terms of PCI planning, morphology, lesion length, diameter, vessel, then it gives you the strategy and the device that you are going to choose. And post PCI, looking at optimization of treatment, especially in particular if you use stent, is with looking at medial dissection, position, and stent expansion. So what is new in the treatment of diffuse CAD? I think what has, if you look in last couple of years, what is being discussed about is actually the pullback pressure gradient. This is in the case that if you have lesion, you use an FFR, you give adenosine for hyperemia, and then you pull back. And then from here, you can actually divide the lesion to either focal or diffuse disease. And this is focal disease on the right side is when there is a sudden drop in FFR. So that denotes focal CAD. Whereas the diffuse CAD is that there's a gradual reduction of FFR from proximal to distal, and you can't really see a sudden drop. And this is a diffuse CAD, and obviously it can be a combination of both. What is the importance of knowing diffuse CAD? Once again, I did allude to before, is that focal CAD, they tend to have more calcified plaque. And this was a presentation just recently showing that if you have diffuse disease, they tend to have more calcified plaque as compared to focal lesion. And as you know, calcified lesions are more difficult to treat. And knowing whether it's diffuse or focal also gives you an idea about the outcome of treatment. So in this case, diffuse disease has much higher chance of a person having residual ischemia as compared to focal CAD. And not just that, the outcome is also different. MACE outcome, the death and MI, and also the risk of target vessel revascularization is much higher with diffuse CAD as compared to focal CAD. Therefore, this paper was actually suggested an algorithm on how we're going to we should be treating these patients based on imaging and physiology. So you can actually have from there either focal or diffuse. If you have focal, then you treat it the same way. And if it's more diffuse, depending on syntax score, if it's low syntax score, then you can still do so-called careful PCI, or if the syntax score is high, then you should even consider cabbage. But you and I, we have these issues about diffuse disease sending for cabbage because the lesions tend to be more diffuse and small, and you'll be wondering what will be the outcome of cabbage in this group of patients. And obviously, it's true, the outcome is going to be poorer than with good targets, isn't it? So DCB base, I think this is something, a flavor that will continue to grow, I believe, and it would appear that it's suitable for patients with diffuse disease because here you want to try to avoid long and overlapping stents. So that's something that is going to come up, and I think in Asia and these parts of the world, the use of DCB is really growing. Now, I just want to share with you briefly two cases of how we treated this. This is a number of years ago, a patient with chronic stable angina, CTO of the LED, and a large diagonal which has severe stenosis. This was crossed and pre-dilated with a 2.5 mm balloon. The results was quite favorable. You can see the TIMI flow has improved. Diffuse disease until the distal end. We treated the distal lesion with a drug-coated balloon. And the proximal had some dissections, and this was a couple of years ago. So we treated that in a hybrid fashion, stented the proximal LED and also the large diagonal and DCB, the distal vessel. And here you can see post-procedure, the flow is good. The distal vessel, of course, obviously DCB is not going to give you as good results, immediate good results as compared to the stents. And this was restudied about 9 months later, and this was about 4 years prior. And you can see that the vessel has actually grown. Index procedure and 9 months follow-up. So still very good, both the stents and the DCB arm. I've made a lot of change in the way that I practice, and this is how I try to do a PCI nowadays for every lesion, if it's possible and indicated. This is a patient who had a fairly acute occlusion of the LED with a diagonal 1 and 2 and a proximal LED which is disease. So we cross this, pre-dilated. Results are Still not very optimum because we were thinking of DCB, and we prepared the vessel much better with a cutting balloon. And there you can see on the right side the results. So we treated this with two DCBs, long DCBs, in the proximal to mid LED. The diagonal 1 and 2 were treated with cutting balloon, and subsequently were treated with DCB. And that was the final results after. Some dissections only mild. This is clearly type A dissections, and the results is good. The flow is good. And that was the final results. We brought the patient back for restudy at 16 months, and there you can see the results. The vessel has actually grown. There's some stenosis in the proximal LED, but that was not significant. And that's the post-index procedure, and 16 months, and he's been well. His LDL was about 10, and with the current medication, LDL is about 1.2. So I think what is required for the treatment of diffuse CAD, obviously further refinement and treatment strategies are still ongoing. It is still a challenge. We need to think carefully about how we are going to treat these patients. Remember, we are not treating lesions, we are treating patients. So obviously, all these things has to come on, not just get immediate good results, but you're talking about long-term results. Physiology assessment with pullback pressure gradient is interesting, is something still very new. So we need to assess how it deals with, from the practical point of view in a clinical setting. The machines now are quite fast in terms of giving our results. Imaging, I still believe is key, even though there's lots of centers that do not have it. We should be thinking about doing more imaging. Good aggressive vessel preparation, because I feel for long lesion, long diffuse lesion, we should be thinking about DCB or DS in a hybrid fashion, as the first case I showed you about. And quite likely we are going to end with hybrid way of treating these patients. Bypass if there is no other options. Thank you very much, ladies and gentlemen.
Thank you, Dr. Rosalie, for an excellent lecture regarding diffuse disease. So before we moving forward with the case from but my hospital Vietnam Heart Institute, I just want to hear the comments from maybe two different countries for this topic. Professor Yeo, can you start first?
Yeah, I think thanks very much, Hui. I think Rosley's talk encompasses many of the ideas that we have. Increasingly, our practice has included the use of drug-coated balloons. When I first started out, I would have a lot more occasions of full metal jackets. Now, I think with the modern drug-coated balloons and the data that's come out, I think is fairly reassuring that we can get away without aiming for angiographic perfection. So I really like Lord Rosley's talk. His illustrations are great, and we pretty much practice in a similar style.
Thank you. Dr. Frankie Tam, any difference in approaching patients in Hong Kong with diffuse disease?
Yeah, I think we are quite similar, right? So diffuse disease is actually a challenge for PCI. In the past, we have to put 2O stands, very long stand from the whole LAD or whole RC down to the PDA. But now I think the DCB has actually changed our practice. So nowadays, many times we may adopt a hybrid approach, right? Proximal, we put a stand, and then mid to distal, then we put a DCB. I think it is quite well adopted in this part of the world. But I think in the coming future, we need to have a more, more wide accepted criteria on when we can put a DCB, when we cannot. Especially, we need more studies data so that this approach can generalize to not Southeast Asia, even to the US, to the Europe, so that we can have a more concrete idea or more clearer, right, for the operators to decide whether we can put a DCB or we put a stent.
Thank you, Frankie. So now I think we are time to start the case. We see how Vietnam Heart Institute, but my hospital team treat their patients with long diffuse disease. So I introduce Dr. Ngọc from but my hospital to present the case. Dr. Ngọc, please.
Thank you, Chairperson and the panelists.
Good morning, everybody.
Located in
Dear Mr. Chairman, colleagues attending the SIP conference. Today, I very honored for us to perform the PCI live case from Vietnam Heart Institute by hospital. Follow me to introduce my team. Next to me, the Dr. Thuan and Dr. Ngọc and Dr. Hao, and two technicians, Mr. Dang and Mr. Hui. And Dr. Ngọc is present of the case.
So we have nothing to declare for the conflict of interest. This case, we have a female patient with at the age of 79 years old, and she has a past medical history of hypertension and type 2 diabetes. And she presented in the hospital 1 month ago for non-STEMI, and we fixed her RCA with one stent. And now she presented with chest discomfort, and the troponin T is mildly elevated, which is 21.3, and EGFR is around 49. And she has heart failure with preserved EF, which is around 68%, and the ECG is normal. So here we have the angiogram of the right coronary. We have the fix at the mid RCA with the one stent DS 1 month ago. And as you can see that we have quite long diffuse lesion of the distal part of the RCA, which we haven't touched yet. And for this current hospitalization, our target lesion is the LAD and also the left main. So we have the angiogram from the spider view. We have the calcification, which is right at the proximal, and the ostium of the LAD, which propagates to the proximal of the LAD. And also there is a angulated circs and very severe diffuse disease. And for the next view, you can see that the calcification runs along from the left main to the LAD. And for the cranial view, There is very severe calcification as also very angulated vessel. And we have very tight lesion at the mid part of the LED, and also very severe disease at the distal part, and provide quite a large territorial myocardium. And we had the first diagonal, which is looks like subtotal occlusion, and also calcified right at the ostium of the diagonal of the first one. So here we have angulated diffuse disease, severe calcified from the left main to the LED. So we like to hear the plan from the panelists. We tried which approach: sheath side, guiding catheter, wire microcatheter, intracoronary imaging, ball and rotor, please.
Okay, so thank you very much for the introduction of the case. Certainly a very challenging case. But before we go and ask about the plans from the panelists, I just want to find out from the panelists in terms of the calcium modification that we're going to do. It's, as you say, angulated and some aneurysmal dilatation. What would be your choice? So would you think about atherectomy or just balloon first? KK, start from you.
This is a nasty case, and if you look at the amount of calcium there, I think you won't be able to have a good, or rather it'll be a lot more painful if you didn't rotoblade. But that angulation in the LED is a bit scary, and I might want to test with a small balloon to see how bad it is first. The LED, I'm more worried about perforation than other vessels, surprisingly, because for some reason those angles are very prone to perforating. So if a balloon works, or a sort of IVL therapy works, then maybe we can avoid it. But sometimes you can't even get an IVL through that kind of stuff. Although some of the more modern IVLs, are trying to tell us they are made of, they're as good as sliced bread. We'll go through everything, but we'll see.
Yeah, I think very tough case. I think times like this, we are very grateful to have a lot of new devices on board as well, like IVL, we have lytics, we have Rota, OAS. I think like what Dr. Rosley said, I think the main thing is you treat the patient. She's 79 years old, so ideally, number one, you don't want to have too many stents because she might not be able to take long-term DAPT. So probably a hybrid procedure. With regards to the calcium modifications, I do agree with KK as well. Because of the angulation, I would try to test with the balloons first and see how it goes. But if not, then most likely it'll be a rotational atherectomy, but be very careful when you burr, probably a smaller size as well. Just be careful about the angulations.
Yes, it's a very difficult lesion. It's a long lesion and very heavy cancer lesion, very heavy. So this strategy patient, I think if it's not suitable for Azotara patient because it's very angle, it's very difficult. So for me, I agree with two experts. First, maybe it's with a small balloon first. After that, maybe we use other special balloon with a cutting balloon or IVL. Then I think it's very safer.
I think definitely imaging is key, isn't it? So Frankie, OCT or IVUS,
Well,
at which point and that you decide.
Yeah, personally, I usually like OCT for calcified lesion, but in this case, it's tight lesion, angulated. I think it's quite difficult to get OCT down. Even the OCT down, the contrast may not flow through. So in this case, probably I will try IVUS.
Left main stent, do you think we should stand into left main?
Well, I think it depends on the imaging. Yeah. So IVUS to look at the plaque distribution, wire bias, everything before we embark on our atherectomy or decide our stenting or DCB strategy.
But angiographically, it looks as if the distal left main stent is.
Yeah, I agree. I agree.
Yes, I think imaging is key in this kind of our approaching if we have to treat this patient. But I have to say that this is the patients that I hate to be faced in the cath labs. Yeah, because whatever you do for the patients, definitely they will come back with you. So I agree with Frankie that maybe sometimes it's not easy to bring the OCT catheter down. So IVUS can be yes, I think it's more flexible in this case, and then depends on what we find in IVUS finding. Then I'm not sure if we can find what we call a healthy zone for implanting the stent. So, but at least I think a balloon first, maybe a small balloon. Try to get the IVUS down, and then see what else we can do. Bigger balloon. If we can bring down an IVL balloon, then it's good. Otherwise, Rotac will be our choice. Yes.
You know, one of the things when I see a patient is that, and a complex lesion is how well they tolerate the procedure. So there are two things that, you know, that usually runs through my mind. If let's say they've got poor LV function, and secondly, if they're elderly, somehow they're very sensitive, especially when you come to complex lesion. If you have to deal with left mains, these are patients you've got to be very more vigilant than others. Obviously, if they have got other comorbidities, it is also important. But you just have to be extra careful when you're doing these cases. Looking up, perhaps you can continue.
So our plan, we choose the 7 French assess, but we upgrade the side of the cheese, which is assessed by the radial approach, and the guiding catheter we use the EBU 3.5, and the workhorse to start with is run through. We have micro support if needed, and yes, we agree. We tried first with the IVUS, and actually we don't have OCT in our cath lab, and we have standby for rota. This is what we have done. So we passed the guide wire, which is the run through, but with a little bit of difficulties. No micro support is needed, but the IVUS catheter was not able to cross the lesion. So fortunately, we did follow the panelists' ideas. We chose the small balloon, which was 1.25 by 15, but we have used two balloon because the first one is rupture, and the second one, and we upgrade the size of the balloon to 20 by 20. The first attempt, which was not well expanded, but the second one, we see that the balloon, the 2.0 by 20 is fully expanded, which was clamped at 224 atmosphere.
So I can see that in this case, the 7 French guy was used, but I can see from the ASAN group, that's mainly when they touch the left main, the 8 French guiding will be the choice. So any of you have an idea that 8 give any more benefit than 7 in left main interventions?
Not really. I think because especially on radial, we tend to use 7, and very rarely that I use an 8 for radials.
Yeah, agree. And you know, I saw that last video on the bottom there, and it's usually quite scary when that thing happens, right? You see it pops. Yeah. So I hope the patient is okay.
Okay. Yep. And this is the IVUS. We estimate the distal diameter is around 3.30, and the proximal and the mean reference diameter is around 3.5 millimeters. And we had mixed blood and the calcification, which runs along from the mid part to the proximal of the LOD, and we have very severe calcification, which is the calcium arches from 20 to 270 degrees, and some of the point is like wrap around like 360 degrees. And then this is the IVUS from the IVUS. So what's the strategy for calcium modification? We use NC balloon only, cutting a scoring, or IVL, please from panelists.
Right. So if you had a look at the angiogram and had a look at the IVUS, do you think there's enough cracks for us to continue with just high pressure balloon and then think about stenting or DCB? Frankie, from your side?
Yeah, so I think when we see the IVUS, it shows us most of the calcium already have fractures and crack inside it. I would say it's acceptable, and of course we can also decide whether we may need IVL, scoring, cutting, or even a root ablation. Or atherectomy, the good thing is we can do debulking. So in the IVUS, we can also observe the wire bias, right? Whether the wire bias is favorable, that debulking may be dangerous or not. It seems that the wire bias is still also acceptable because most of the time the wire touch closely with the calcium. So I would say that it depends, right? If the patient is elderly, frail, probably I would just go on to a balloon-based strategy, right? Scoring and then put in a stent. If the patient is young, fit, probably if we want to achieve better, then we may need an atherectomy to do more debulking before we put in a stent.
So I think, Frankie, you mentioned about maybe higher risk of doing a rotablation debulking for these patients, especially in patients with old age and with frailty. So if you goes on a balloon-based strategy, then your next balloon will be a cutting balloon or any kind of other balloons that you suggest.
So in this case, I think see whether cost is an issue. If cost is not an issue, probably I will choose IVL. If cost is the issue, then I will choose a scoring balloon.
And then the new balloon from Alexia, the lytics, is it any any
I didn't
use
have
of
any
this?
experience of that. Maybe Dr. Rosley, you can share with us your experience of the lytics. Yeah.
Okay, I think we will continue to see the case afterwards. But your thoughts, Fuzzy? What do you think? Enough? But cutting balloon, I'm a bit concerned because of the aneurysm. So
Yeah,
front
I think that this conspicuous IVUS is very heavy and maybe 360 degree and about both superficial and deep consideration. If the first choice, if the IVL is, I think it's number one. And if we don't have IVL, we can use cutting balloon and scoring balloon and very high pressure balloon. I think after the preparation, after we put stents, I think that.
Yeah.
yeah.
I think looking at the IVUS, I think the minimum will be an NC balloon because you can see there's some minimal cracks, but the expansion is still very poor. So if you put in the stent might be very difficult to be well expanded. So I think the minimum is an NC balloon, but I think if the cost not an issue and we have the devices, I will either opt for either IVL or even the new lytics balloon. I mean, I have minimal experience. I think Rosalie and Shelvam and others have got more experience in it, but I would definitely try and modify the plug a bit more better so that we have better expansion when we implant a stent.
I think the importance over here is that we are trying to optimize the calcium modification in a more probably safe and hopefully in a more predictable manner. I think that's the most important thing because sometimes with the non-compliant balloon and so on, you have difficulty in terms of controlling this. So I think
Yes. And as the IVUS show, we have some of the calcification crack, but yeah, the lumen area is not what we wish for. So our plan actually is this is the Bolin-based strategy. So we chose the lithic, which is the low-profile metallic hemisphere, uh, and uniformly distributed, and the hemisphere runs along the way of the Bolin body. And you can see that we have like this is a kind of short balloon, and based on the IVUS, we have this the reference is 3.0, so we chose the 30 by 14 balloon from the lithics. And this is the balloon that we have used. And we use just one balloon, which is 30 by 14, and we applied from the mid part of the LED to the proximal. And the key the key thing is that we go low and slow. So we inflate to start with just 2 atmosphere, and every 5 to 10 seconds we goes up to every 2 atmosphere, and for the mid part we goes up like 2, 4, 6, 8, 10, and 12 atmosphere, which is the rated burst pressure. And for the proximal, from the right side, from the right video, although the diameter for the proximal is estimated around 3.5 millimeters, and we've inflate the 30 by 14 balloon, which is a 20, and we have a small test to see if the balloon is big enough, or we can goes up a little bit higher, and we did a stand boost to check for the balloon expansion.
So Dr. Ngọc, because this lithic balloons is considered new in Vietnam,
Yeah.
so any recommendations from your team that do we need any special preparations or balloon before advancing into the lesions?
Yeah. So based on this case, is still a balloon-based strategy. So we have to use like the small balloon first to check for the passage of the balloon throughout the vessel body, and sometimes we have to use the non-compliant balloon to make it more easy to get through down to the downstream, and the size of the balloon we have to choose like 1 to 1 to the vessel of the diameter, and we just go from very low pressure and keep for minimum like 5 to 10 seconds, or even more like 15 seconds for. And one of the things is that you have to use uh, multiple attempts, like 8 to 10 attempts for eccentric um, or maybe calcium nodules for more sophisticated. And after we use the lithics balloon, we check the flow of the LED. We see that there is also the vessel is open up, but we can see that some dissection of the mid to the proximal of the LED.
So Dr. Frankie Tam, are you happy with the balloon dilatations?
Yeah, I think for the mid to distal, it looks okay to me. But if uh, but for the distal left wing and the osteoid, I'm not sure it is good enough or not. So I think we need imaging, such as IVUS, to look at the area cracks to visualize the distal left wing. And also the proximality, because actually from previous IVUS we know that at that area the calcium is very thick and quite concentric, 270 to 360 degree. So I think that area, if you want to tackle the left wing and proximality, then we may need to do more there. But for the mid to distal, it seems it's okay to me. Yeah.
Yes, so this is the IVUS for the post lithics balloon. We have 8 attempts, and the pressure is 12 or more atmosphere, and so based on the IVUS findings, you see that the number of reverberation is like 2 or 3 degrees. So is this classified currently IVUS adequate for stenting, or we need more lithics more, or any other modified devices needed?
Dr. Yeo?
I think for some of these cases, to be honest, I think this looks adequate. Again, depending on the patient and how much more you want to achieve with this kind of cases, one may accept that the result. The IVUS for the left main, let's see. I didn't catch all of it, but what was the MLA and ostium of the circ and the distal left main?
Yeah, it is. We are reaching for the
What is recommended is after a lithics balloon, you should go back in with a non-compliant balloon to ensure that you get the best calcium modification. So in this case, the left main stem it looks quite good. Left main stem was 3.5 at least, then you should go in and open up with a 3.5. It's the same when after you do rotablator OS. So go in and get better results before you implant the stem.
Yeah. And then we proceed with the stenting.
So one question here, before you implanting the stent, any of you will put a down wire to a circumflex? So Fazir?
I mean, if you're going to embark on the left main, of course, you need to have the wire to the circumflex. You probably need to dilate the proximal circumflex as well. Probably I will DCB the prox circumflex. So I will treat the LAD up to the prox LAD, then I will go to the circumflex, probar the circumflex, maybe DCB that, and then just a short proximal DCB, and then complete with the left main to LAD if that is required. But yeah, but I would dilate a bit more of the left main if I'm going to do that as well.
Yes, we fix the mid and the proximal LOD with two stand. The bit is 3.5 by 32 millimeters, and the proximal is 40 by 28 millimeters.
Okay. The only thing is, if you know about Dynamics, I mean, Vietnam uses more Dynamics than other countries in Asia, I think. So you've got more experience with it. Obviously, the links are only bonded by the polymer, and once the polymer is absorbed, then it releases it and allows you to have this flexibility. And the only thing which is the thing which is good about Dynamics is that it has got a mortality data favoring it over Onyx in for LED. So I believe that that's quite compelling. But for others like left mains and so something that needs we probably need to have a bit more data with that.
So initially, we evaluate on the angiogram that the circ is very diffuse disease, and also the RCA is quite dominant, and the angle of the circ and the LAD is quite angulated, which is nearly 90 degrees. So so we decide to go straight forward to stenting the left main to the LAD.
So it means that you didn't wire the circumflex.
Yeah,
Okay.
that's a problem. So the stand for the left main to the proximal LID is 40 by 23, which is 14 atmosphere, and then this is the problem. We got the compromise of the surge, and there is some of the times no flow, and there's slow flow of the surge.
So let me ask, Dr. Van, will you rescue Cirque now?
Yes, of course. Because you can notice after stenting mid LED, we see flow in as complete is TB2. So we must rescue in this situation. So.
The problem is that if you see the origin of the silk, it's not easy because it comes from a different origin, isn't it? It's not fairly straightforward. I think it's going to be quite a challenge to try to wire that.
I mean, also the other thing is talking about branches as well. Look at the diagonal. So I think I was just looking at it just now whether we could have done a hybrid approach for her because number one, it's going to be a very long stand. She's 79 years old, a lot of metal. So I think maybe if the dissection was not so bad after latex, maybe a hybrid would be better. Number one is you can see the diagonal flow is also compromised, the circ flow is compromised. So sometimes we prefer hybrid for especially elderly patients.
And here, and one of the modest questions is that what is the most appropriate that cause cyber compromise? Which do you think is plug shift, kernel shift, and from if we can restart from the beginning, we do have like two stand strategy or just gel balloon or like DCB for the circs.
Yeah. Fazil, you.
Yeah, I mean, as I mentioned earlier, I think I've always preferred DCB for the osteo circumflex because stenting is never a good option for osteo if you can avoid it, if it's not too dominant. So definitely wire, I would still balloon it and probably some form of DCB modification if I were to do it again. Yeah.
You know, I think that this case illustrates that sometimes the best laid plans don't go as planned. The value of the discussion is that you have more than one way to skin a cat. There's more than one way of doing something. And although you have a statistically superior result with A versus B, it doesn't mean that B is always bad. It just means that you're more likely to get a good result with A if you choose A all the time. But you know, in interventional cardiology, nothing is the same all the time. So having an awareness of the literature helps. But I just want to say that it's easy to it's sometimes not so straightforward, and I accept that we sometimes have to choose and then adjust accordingly. In this case, well, whether it's plug shift or carina shift, I will go after it. And then even though one would say that the circumflex may segment a large amount of territory, I might just try the balloon and see what happens first, bearing in mind that this is a very calcified area, and that trying to do something complex may not be so easy. So I would just wire and balloon and see what happens.
So Frankie, from point of view, plug or coronal shift?
Yeah, I think both can happen. It depends on where the plug distributed. But most of the time, it's likely to be Carolina shift. Unless there's a big soft plug proximal to the bifurcation opening, then it's likely to be plug shift. So most of the time, Carolina, but both can happen.
Yes. And yeah, the patient's blood pressure drops down like 5 to 10 minutes, and we have some difficulty with assessing the side branch. We used the Warhorse Y, which was the run through, and then the Cyan Blue will fail. So we have the Sasuke support, which is the dual micro catheter, and the attempt was success with the guy first, and we pre-dilate a little bit with the 2.5 by 20 millimeters normal balloon, and later we achieve the flow of the circs. And yes, we did DCB, which is 2.75 by 20 for the circs, and then we did the KBT for both of the LD and the circ, and we did the pot by the 4.50 balloon. And as you can see on the imaging, we achieve both flow from the circs and the left main to the LED. And after we achieve the flow of the circs, the patient is getting more stable and the blood pressure getting up. And of course, with Lythix balloon, we post-dilate with the NC balloon for the mid and proximal of the LED because the patient is quite stable now. And we achieve good flow, and the IVUS shows as below. So the post-implant minimum lumen diameter 3.5 millimeters, and the residual stenosis is minimal. And final plan expansion, we think that the stent expansion result is achieved. Yes.
Right. I think the staining in the circ, at least that's type C dissection. But in the end, the flow is still very good. You waited for a while before taking the final images. So what is important is still the flow. Otherwise, if you're going to stent it, it's going to be really more complex. And the dissection was, looking at it, was due to wire, went suboptimal during wiring.
Yeah, we waited for 10 minutes, and we have the second angiogram, and we saw that the flow is still there. So we decided to stop the procedure.
Yeah. Maybe Frankie, any kind of dissections after like this you can accept, or you want to go ahead and then treat in very aggressively?
Yeah, so most of the time, classical teaching is type C or above, right? So as Dr. Ross has mentioned, this is type C. So if usually I will handle this, but taking consideration this case, complex, elderly, calcified circumflex, so sometimes we have to balance the risk and benefit. And of course, flow is still the most important thing, right? So if the flow is okay, we wait for a while, everything's okay, we may have to accept this.
I just want to say that this is a very well, executed case in a very complex patient with a horrible anatomy. Most of us would not want to do this in a live case at all because so many things can go wrong. And but I think you have demonstrated very nicely some of the challenges and the use of novel technology with the Lythix balloon, which has a very novel mechanism of action and clearly efficacious in this case. And I think that's the value of such live cases, because we get to see real life examples of challenging cases and how you deal with the complications. I agree with what the team has done. I wouldn't have gone after that circ. It's dissected, yeah, it looks ugly, sure, but patient is alive, that's most important. You want the patient to go home to the family. So I think a very difficult case that you have nicely illustrated your strategy and how you dealt with the challenging aspects of it. So congratulations.
Yeah. So we're happy the patient was discharged 5 days after uneventfully. So our case message: the challenging along the PCI procedure with multivessel disease, diffuse calcified lesion, and bifurcation left main and side branch unprotected. And lesion should be well prepared with IVUS guided, and lithics should be considered. Be simple, provisional, but also be well prepared for complex.
Thank you for kind attention from PCI Lai Kai from Vietnam Heart Institute by my hospital. See you next year in the SIP 2026.
Dr. Ngap, thank you very much. So I think that's the importance of treating calcified lesion. Again, in terms of with special regards for imaging, I think it is very important because we're dealing with two important aspects, a couple of important aspects in this case: calcified lesion. Therefore, the planning of the treatment, left main stem. I believe left main stem you should image, unless of course you can't. And the thirdly is a long lesion, and therefore the plans in terms whether you can actually do a hybrid procedure and reducing the amount of stent in a vessel. Special regards to lithics. The lithics is a mechanical IVL. It's as I was just sharing with Prof. Yo, is that it's a bit different. It's like a focus in the sense. The difference is that the pressure, because the normal cutting balloon, scoring balloon and non-compliant balloon, it depends on the pressure. So you inflate, the higher pressure, the higher the force onto the lesion. But in this case, because of microspheres and it has got small contact, when you have small contact, you are able to amplify the force. So in this case, 5 atmospheres is equivalent to 60, 12 atmospheres is equivalent to 80. So the amount of pressure or that you are able to exert is much higher than when compared to the focal stress balloon. So it's different in that sense. And you don't have to have any outside energy or source. It's just a plain balloon. It is not as trackable as a normal semi-compliant balloon, but it is good enough, and it's been shown again and again. If you pre-dilate it with a smaller balloon, you don't have to go high pressure. You can deliver this lytics balloon quite comfortably, and you can inflate as many times as you can, as long as you understand the limitations. And for not just one vessel, you can go for 2 vessel, as long as sometimes it depends on the angle and so on, and you can do multiple inflations. Anyone, Fazeh? You've done enough?
Yep. Yeah.
Why don't you close this? Thank you.
Okay, thank you, Dr. Rosalie. On our panels, we have an interesting case with lectures from Dr. Rosalie, how we can approach diffuse disease. And then after that's a really exciting case from Vietnam Heart Institute team that they have did very successfully. So thank you, and we close this session.